Welcome to the Depth Dive. Today, we're really getting into social anxiety disorder, or SAD. Sometimes it's called social phobia, too.
That's right.
And look, this isn't just feeling a bit awkward now and then. We're going to unpack what the science, the medical and psychological sources actually say it is.
Yeah, because it's definitely more complex than basic shyness.
Absolutely.
And one thing that jumps out right away from the research is just how differently its frequency has been reported. You see numbers like, what, 7% back in
Yeah,
2003?
right.
And then others soaring up to, well, maybe even 36% more recently, around 2020.
Wow, that's a huge range.
It really is. And that difference, it kind of hints that maybe our understanding or even how we talk about social anxiety has shifted quite a bit,
Hmm.
or perhaps how common it actually is.
That makes sense. And something the sources emphasize right up front. SAD is not the same as just being an introvert or being shy.
Definitely not. They're distinct things.
Okay, so let's get down to it. What really defines social anxiety disorder? What are its core features?
Well, at its heart, SAD is about this really intense fear and anxiety related to social situations.
Intense is the key word there.
Yeah, it's not just mild discomfort. It causes significant distress, and it can really get in the way of daily life, impairing function in work, school, relationships.
Okay. And what tends to trigger it?
It's often triggered by the feeling, whether it's real or just perceived, of being watched, scrutinized, or judged by other people.
Ah, that feeling of being under a microscope.
Exactly. And the core fear, the deep down worry, is about being negatively evaluated, being seen as awkward, stupid, unlikable.
That sounds incredibly stressful. So how does this anxiety actually, show up? What might someone feel physically or do?
Physically, it can manifest in some really noticeable ways. Things like excessive blushing, suddenly sweating a lot, trembling, maybe shaky hands or voice,
Yeah.
palpitations, that feeling of your heart racing or pounding, muscle tension too, feeling short of breath, even nausea.
Nausea.
Yeah. And in really intense situations, it can even trigger a full-blown panic attack.
Gosh, those physical symptoms alone sound incredibly difficult to manage when you're trying to interact with people.
They really are.
And our sources also mention some less obvious ways it can appear, like coping mechanisms.
Yes, exactly. Maladaptive coping strategies can develop. Sometimes people might turn to alcohol or drugs to try and, well, lessen their fears or feel less inhibited socially.
Sort of self-medicating?
Precisely.
Yeah.
Especially if they haven't been diagnosed or aren't getting help. But that, unfortunately, can lead down a path to substance use disorders or sometimes even eating disorders, creating a whole other layer of problems.
It's a really tough cycle, needing something external just to face a social event.
So for diagnosis, what do clinicians actually look for? What are the criteria?
Well, looking at the ICD-10 criteria, one of the main diagnostic systems, key things include a really persistent fear of being the focus of attention,
Okay.
or a fear of behaving in a way that will be really embarrassing or humiliating.
So that fear of negative judgment again. Yes. And along with that, there's usually significant avoidance of those feared social situations. Plus, the presence of those anxiety symptoms we just talked about, the physical or psychological ones when they are in those situations.
So it's the fear, the avoidance, and the actual anxiety symptoms combined. Got it. Now let's try and get inside the head of someone with SAD. What's going on cognitively? What are the thought patterns like?
Cognitively, there's often a lot of dread before social events even happen. A huge amount of mental energy goes into worrying about how they'll seem to others.
Like pre-worrying.
Yeah, pre-event rumination is common. And then during and after the social activity, there's often intense self-consciousness. They might hold themselves to really high, often totally unrealistic standards for their social performance.
Like they have to be perfect in every interaction.
Kind of. It's like they're constantly reviewing their own performance, usually very critically.
And our sources mention this idea of wanting to make a good impression but feeling like you just can't.
Exactly. There's often this strong desire to connect and be liked. But underneath it is this deep-seated belief that they're incapable of doing it successfully.
That must be frustrating.
Incredibly. And it leads to that pre-event rumination we mentioned, minds racing, playing out worst-case scenarios, planning how to avoid potential problems.
Exhausting.
And then afterwards, there's often this post-mortem where they feel they performed poorly, interpreting any tiny perceived flaw as a major social blunder. These negative thoughts can linger for a long, long time.
Wow. And this connects to something called cognitive distortions, right? That's a key feature.
Yes, absolutely. Cognitive distortions are like these skewed negative filters people with SAD view themselves and social interactions through. They're inaccurate, unhelpful ways of thinking.
And CBT targets those.
Exactly. That's a major focus of cognitive behavioral therapy.
Yeah.
Someone might have this internal monologue that's just relentlessly negative, self-critical. And research suggests they also tend to recall negative social memories much more easily and vividly than positive or neutral ones.
So past stumbles feel much bigger and more present. It really makes it clear how this goes way beyond just being a bit reserved or quiet.
Oh, absolutely. SAD often leads to significant social avoidance. It genuinely interferes with life. Specific fears might include intense worry about being judged by others, feeling incredibly anxious around authority figures, bosses, teachers,
Sure.
even things like feeling really uncomfortable during a routine physical exam with a doctor.
And how do these internal feelings translate into behavior? What might someone actually do that others could notice?
Behaviorally, you might see self-isolation, someone seeming quite distant or withdrawn in groups, maybe avoiding eye contact, blushing frequently.
Right.
Interestingly, some might find a sort of refuge in online interactions, social media, but that can sometimes become problematic if it replaces face-to-face connection too much.
A double-edged sword.
Yeah. Sleep problems are also common, and there's often this huge sense of relief when they manage to avoid a feared social event.
But that relief reinforces the avoidance, right? Making it harder next time.
Precisely. It's a powerful but ultimately unhelpful cycle.
And what about the long-term effects of living with untreated SAD?
Well, over time, it can really chip away at self-esteem, fuel persistent negative self-talk, and significantly increase the risk for developing major depressive disorder.
So there's a strong link with depression.
Very strong. Also, increase sensitivity to criticism, and it can hinder the development of social skills, or at least the confidence to use them. This anxiety can really permeate almost every area of social life, big things like job interviews or dates,
Yeah.
but also just everyday stuff like making small talk at work or interacting with a cashier.
It really paints a picture of how significantly this can impact someone's overall quality of life. Okay, let's broaden the view slightly. The research talks about comorbidity SAD often showing up alongside other issues. How common is that?
It's actually very common. One large study found something like 66%. Two-thirds of people with SAD also had at least one other psychiatric disorder.
2/3. Wow.
Yeah. And the link with low self-esteem and clinical depression is particularly strong. People with SAD are estimated to be somewhere between 1.5 and 3.5 times more likely to also experience depression.
And does the type of social fear matter in that link?
It seems so. Research suggests that specific fears like avoiding small group gatherings or parties might be more strongly associated with triggering depression compared to, say, performance anxiety alone.
Interesting. What about other anxiety disorders? Does SAD overlap there too?
Oh, yes. There's a high rate of co-occurrence with other anxiety disorders. The connection with avoidant personality disorder is particularly notable. Depending on the study and population, the overlap rates reported range quite dramatically, from maybe 25% up to nearly 90%.
That's a huge range, but clearly a significant connection. We touched on substance use earlier as a coping method. What's the bigger picture there?
It's a bit complex. Estimates suggest around 20%, or 1 in 5, individuals with SAD also struggle with an alcohol use disorder. Often it starts as a way to self-medicate, to ease anxiety in social settings.
Makes sense.
Though interestingly, some research has hinted that SAD might, in some ways, be protective against certain alcohol problems, perhaps due to the avoidance aspect. But that's still debated.
Okay.
What does seem clearer is that having both SAD and an alcohol use disorder can make treatment more challenging, particularly group therapy, and it increases the risk of relapse for the alcohol use.
That sounds like a really difficult combination. Are there links with other conditions too, beyond anxiety and depression?
Yes, the sources mention associations with bipolar disorder and also ADHD. It suggests there might be some shared underlying vulnerabilities or predispositions.
ADHD. How does that connect?
The co-occurrence of ADHD and social phobia seems fairly common, especially when something called cognitive disengagement syndrome is present. That basically involves difficulty shifting attention, getting stuck on thoughts, which you can imagine would make fast-paced social interaction even harder.
Yeah, absolutely. It's fascinating how interconnected these things can be. Okay, let's shift now to the why. What actually causes SAD? It seems like it's probably not just one thing.
Definitely not. It's multifaceted. Genetics certainly seem to be part of the puzzle.
How strong is the genetic link?
Well, if you have a first-degree relative, a parent, sibling with social phobia, your risk is about 2 to 3 times higher. Twin studies estimate heritability somewhere in the 30% to 50% range.
So a significant chunk.
Yes, But it might be more of a general predisposition to anxiety disorders, not just SAD specifically. And environment matters too, of course.
Right.
Research shows parents of people with SAD tend to be more socially isolated themselves.
Right.
And even shyness in adoptive parents correlates with shyness in their adopted kids, suggesting learned behaviors or environment alongside any genetics.
So nature and nurture both playing a role within the family. What about specific parenting styles?
Yeah, certain styles seem to increase risk. Things like being overly protective or highly critical parenting.
Okay.
Also, insecure attachment in infancy, specifically what's called anxious ambivalent attachment, has been linked to a higher risk of anxiety disorders, including SAD later in adolescence. That early relationship security seems pretty important.
That foundational experience really matters. The sources also mention infant temperament, like being born a certain way.
That's right. About 10–15% of babies show what psychologists call behavioral inhibition. They're naturally more introverted, cautious, maybe fearful in new situations or with new people.
But like a predisposition to shyness from the start?
Sort of. And while not all behaviorally inhibited infants develop SAD, a good portion of them continue to show these traits, and they do seem to be at higher risk for SAD later on.
Okay, so you can have this underlying temperament. What about specific life experiences? Can bad social events trigger it?
Oh, absolutely. A really negative social experience, something traumatic or humiliating, can definitely act as a trigger or worsen existing anxiety. This seems especially true for people who are already quite sensitive interpersonally.
Makes sense.
For about half the people diagnosed, they can often point to a specific difficult social event that happened before the SAD really took hold or got worse.
Like public speaking going badly wrong.
Exactly. That kind of thing is often linked more to specific phobias, like a fear of public speaking.
And it's not just things that happen to you, right? Can seeing things happen to others or being warned about things have an effect?
Yes. Witnessing someone else have a really negative social experience, or even just hearing detailed accounts of it, can contribute. Same goes for getting frequent warnings about social dangers or how easy it is to make a fool of yourself. And then there are the longer-term effects of things like not fitting in, being bullied, feeling rejected or ignored repeatedly. That cumulative impact can be really significant. Studies show kids who are less popular often report more social anxiety.
So a whole range of social learning, direct and indirect. Going back to parenting, you mentioned overprotective and critical styles. What about others?
Well, on the flip side, warm, sportive parenting seems to be protective, correlated with a decreased risk. But negative styles like overcontrol, harshness, criticism, verbal abuse, those are generally linked to poorer outcomes, insecure attachment, and higher SAD risk.
It really highlights that complex mix of inherited tendencies and lived experiences. What about culture? Does the society you live in matter?
Hugely. Cultural attitudes towards shyness or social avoidance vary a lot. This can affect relationships, opportunities, everything. And the role of shame is really key in some cultures.
How so?
Well, one study found in American families, parents emphasizing others' opinions and using shame for discipline was linked to higher social anxiety in kids. But interestingly, that link wasn't found in Chinese or Chinese American families in the same study.
Oh, that's fascinating.
Yeah, and in some East Asian cultures, childhood shyness or inhibition might even be viewed more positively, maybe as a sign of thoughtfulness or competence, which is quite different from many Western views where assertiveness is often prized.
That really shows how context shapes the meaning of behavior. What about social skills? Is it that people with SAD lack the skills, or is the anxiety just getting in the way?
That's a good question, and the research is a bit mixed on actual skill deficits. Some studies find them, others don't. But what seems pretty consistent is that people with social anxiety tend to perceive their own skills as being much worse than they probably are.
So it's more about self-perception and confidence.
Often, yes. Though some argue that maybe modern life, with its increasing demands for social interaction and self-presentation, might make things harder for people prone to anxiety, that need for social fluency.
Right. The pressure is higher, perhaps. And psychologically, beyond just experiences, what else is going on? Core beliefs.
Yes, psychological factors are central. This includes negative core beliefs about the self. Things like, I'm inept, I'm unlikable, I'm fundamentally flawed.
Deep-seated stuff.
Very.
Yeah.
And conditional beliefs, too, like if I show anxiety, people will reject me. Or if I speak up, I'll say something stupid. There's also this idea of self-concealment, trying hard to hide the anxiety and these negative beliefs.
Which must take a lot of energy.
Absolutely. And worries about self-presentation, the fear of negative evaluation we talked about. The anxiety itself then interferes with performance, which can create more social problems, reinforcing the whole cycle.
Vicious cycle indeed.
People become hyper-focused on their anxiety symptoms. Are they noticing, I'm blushing, shaking?
Yeah, right.
They often distort how they think they appear to others,
Yeah.
usually assuming the worst. Past negative memories get replayed, lots of rumination, and even subtle avoidance or safety behaviors, things meant to reduce anxiety in the moment, can actually make it worse long term.
It's such a complex internal landscape. Okay, so given all this, how does someone actually get diagnosed? What are the steps?
Well, clinicians rely on diagnostic criteria, like those of the ICD-10 or the DSM-5. The ICD-10, for instance, defines it by that fear of scrutiny leading to avoidance, plus those physical or anxiety symptoms like blushing, tremor, nausea, maybe urinary urgency, sometimes escalating to panic attacks.
Right.
And to help assess severity and screen for it, they often use standardized questionnaires, things like the Social Phobia Inventory, the Leibowitz Social Anxiety Scale, tools like that.
So standardized measures help objectify it somewhat, and the DSM-5 has its own specific criteria.
Yes, the DSM-5 provides a detailed list to help distinguish SAD from, say, normal shyness or other issues. Key points include that intense fear of social situations involving possible scrutiny.
Okay.
For kids, it has to happen with peers, not just adults. The situations almost always provoke fear and are avoided or endured with intense anxiety. The fear has to be out of proportion to the actual threat, considering cultural context.
Disproportionate is key there.
Yes, and it needs to persist for at least 6 months and cause significant distress or impairment in life. Crucially, it can't be better explained by substance use, a medical condition, or another mental disorder like panic disorder or body dysmorphic disorder.
So ruling other things out is important.
Very. And the DSM-5 also specifies a performance-only subtype if the fear is restricted just to public speaking or performing.
Gotcha. And didn't the DSM criteria change regarding autism?
Yes, that's a good point.
Hmm.
Earlier versions used to exclude an SAD diagnosis if symptoms seem better explained by autism spectrum disorder, but DSM-5 recognizes they can co-occur. You can have both.
Okay, that makes sense. They also consider potential overlap with bipolar or ADHD when diagnosing.
Right. Those need to be considered in the differential diagnosis process, making sure the symptoms fit SAD best, or acknowledging if multiple conditions are present.
Okay, that clarifies the diagnostic picture. Now, the crucial part, what helps? What are the main treatments for SAD?
The most recommended first-line treatment is psychotherapy, specifically cognitive behavioral therapy, or CBT.
CBT comes up a lot.
It does, because it's got strong evidence behind it. It works well individually or in groups. The focus is on identifying and changing those unhelpful thought patterns and learning better ways to cope with the physical reactions in social situations.
And you mentioned earlier, interest in treatment grew around the time medications were approved.
Yes, around 1999 onwards, there was definitely increased attention, partly driven by new medication options becoming available and marketed for SAD.
So therapy versus medication, how do they compare?
Generally, while meds might offer quicker symptom relief initially for some people, CBT tends to produce more lasting, durable benefits. The skills you learn in therapy stick with you.
That makes sense.
Self-help, based on CBT principles, is often seen as a good second-line approach too, maybe for milder cases or as a starting point.
What about other therapies, like ACT?
Acceptance and commitment therapy, ACT, is gaining evidence as another useful approach, possibly second line. Its a bit different focus is more on accepting difficult thoughts and feelings rather than fighting them, and committing to actions aligned with your values, even when anxiety is present, building psychological flexibility.
Interesting alternative focus. What about social skills training specifically? Does that help?
It might. Some programs focus on skills like conversation, assertiveness, friendship building. The research is a bit unclear if specific techniques are essential beyond just general support and gradual exposure to social settings, which is part of CBT anyway.
So maybe the confidence gained from therapy and exposure naturally improves skills.
That's often the idea, yeah. As anxiety reduces, people feel more able to use the skills they likely already possess.
Okay, let's talk medications then. When are they typically used?
Medications are definitely an option, especially for more generalized SAD. The first choice pharmacologically is usually an SSRI, a selective serotonin reuptake inhibitor.
Like antidepressants.
Yes, many are used as antidepressants but are also effective for anxiety. Examples approved for SAD include paroxetine, sertraline, escitalopramol, venlafaxine XR, and fluvoxamine CR are others.
Can you mention they're generally considered second line compared to CBT?
Overall, yes, but they are first-line pharmacologically. They're generally preferred over older meds because they tend to be better tolerated and have less risk of dependence.
Are there side effects to be aware of?
Yes, especially initially. Common ones can include things like headaches, nausea, maybe trouble sleeping, some sexual side effects. These often lessen over time as the body adjusts.
Good to know. What if SSRIs don't work or aren't tolerated? Are there other medication options?
There are. Before SSRIs, monoamine oxidase inhibitors like phenelzine were sometimes used. They can be effective, but they come with significant dietary restrictions and drug interaction risks, so they're usually a last resort now.
Right, the cheese effect and all that.
Exactly. There are also RIMAs, reversible MAOIs, but they seem less effective. Beta blockers, like propranolol, can be useful sometimes, but mostly just for performance anxiety, like stage fright, to manage the physical symptoms, like rapid heart rate.
So, more situational use for beta blockers.
Right. Other things like anticonvulsants, older tricyclic antidepressants, benzodiazepines, antipsychotics, even St. John's wort, they aren't generally recommended as primary treatments for SAD.
What about benzodiazepines like Valium or Xanax? People sometimes think of those for anxiety.
They can provide quick, short-term relief from severe anxiety, which might seem helpful. But long-term use is really discouraged due to risks of tolerance needing more for the same effect, impairment, dependence, and difficult withdrawal. They don't address the underlying issues like CBT does.
Okay, so SSRIs are the main medication route, but therapy is generally preferred first. Now, let's get a handle on how common this actually is. What does the epidemiology tell us?
Well, a striking thing is how early it often starts. About 50% of cases develop by age 11.
Wow, that young.
Yes, and 80% by age 20. This early onset is concerning because it can make people more vulnerable to other problems later on, like depression or substance use issues.
Definitely highlights the need for early recognition. How prevalent is it overall?
Figures vary. The big National Comorbidity Survey in the U.S. back in the 90s found a lifetime prevalence of around 13.3%, making it one of the most common psychiatric disorders, maybe third after depression and alcohol use disorder.
13% lifetime prevalence is huge.
It is. More recent NIMH data suggests it affects maybe 15 million American adults annually, with yearly prevalence estimates often cited in the 2% to 7% range for U.S. adults.
Still very significant numbers.
Absolutely. Mean age of onset is usually between 10 and 13. It's pretty rare for it to start after age 25, and if it does, it's often linked to another condition popping up.
And is there a gender difference?
Yes, it appears to be diagnosed more often in females than males.
Interesting. And what about globally? Do rates differ much between countries?
They do seem to vary quite a bit, though comparing studies can be tricky due to different methods. We see rates like maybe 0.4% to 1.8% reported for young people in parts of the UK a couple of decades ago. Australia around 1% to 2.7%.
Okay.
Then you see higher figures sometimes like 4.7% to 7.9% in Brazil, maybe 13% in adolescents in one Indian study, but under 1% in Iran in another. Israel around 4.5%. University student samples often show higher rates, like over 9% in Nigeria, 16% in Sweden, nearly 10% in Turkey.
So quite variable.
Yes. Poland, 7-9% in one report, Taiwan around 7% in kids. It highlights how cultural factors or reporting differences might play a role, and that challenge of separating SAD from shyness can definitely lead to these wide estimates.
That makes sense. It's complex to measure consistently worldwide. Lastly, what about ongoing research? What are scientists still trying to figure out?
A big area is the underlying neurobiology. It's still not fully mapped out. Research is focusing hard on neurotransmitters serotonin, dopamine, glutamate, and using neuroimaging like fMRI to pinpoint brain regions involved. The amygdala, involved in fear processing, consistently comes up.
Trying to find the brain basis.
Exactly. They're also looking more at how factors like parenting styles or stressful life events interact with potential genetic predispositions. We know genetics play a role, but the specific genes or reliable biomarkers haven't been nailed down yet.
So still lots to learn about the fundamental causes and mechanisms.
Right. Well, we have covered a lot of ground today, really digging into social anxiety disorder.
We certainly have.
We've seen it's much more than just shyness. It involves intense fear, significant distress, avoidance, and a whole host of physical and cognitive symptoms.
Yeah, and we've touched on those unhelpful coping strategies that can sometimes emerge.
We explored the potential causes, that mix of genetics, brain function, psychological factors, early experiences, social learning, and even cultural context, and how it's diagnosed using specific criteria, ruling out other conditions.
Plus, the main treatments. CBT being the preferred first step, offering lasting skills and medications like SSRIs as another key option.
And we looked at how common it is, often starting young, and its tendency to occur alongside other issues like depression.
Which really underscores why early recognition and getting help is so important.
Absolutely.
So to leave you, our listener, with something to think about, considering how our understanding of SAD is changing and how prevalence seems to vary, maybe even influenced by culture, how might our increasingly digital world, with social media and different ways of interacting, further shape how social anxiety shows up and how we recognize it in the future?
That's a really interesting question. It might be worth reflecting on your own social interactions, maybe where you fall on that spectrum of social comfort and connection in today's world.